And thank you so much for joining us today. I want to welcome you all and remind you to please share your questions and comments with us in the chat today. I also want to remind you that we'll have a little bit of time allotted for participants during our live webcast today to complete a very brief post-assessment following our presentation and our discussion. And as always, we encourage you to contact our team at cessationta@lung.org. This webinar is made possible through a cooperative agreement with the Centers for Disease Control and Prevention. And I do want to remind everyone that the views expressed within this webinar do not necessarily reflect those of the CDC. And very important, all references to tobacco and tobacco products within this presentation refer to commercial tobacco and nicotine products and not the tobacco or other plant mixtures that are grown or harvested and used by Indigenous people for sacred purposes. So in 2024, I'm excited to say that the American Lung Association is proud to be celebrating 120 years. Since 1904, our organization has remained steadfast in our mission of saving lives by improving lung health and preventing lung disease. As long as anyone struggles to breathe freely, our association will be there to champion healthy lungs. Guided by strong moral compass and a sense of optimism, we will continue to advance our mission and realize our vision of a world free of lung disease. We helped to pioneer a model of education, advocacy, and research to address public health issues. The Lung Association was among the first to make the connection between air pollution and lung health, and we advocated for clean air. We helped to eliminate smoking on domestic flights, championed the passing of the Tobacco Control Act, and helped to achieve increasing the age of sale for all commercial tobacco products to age 21. And our work continues today. So I want to introduce you to myself and my teammates that work on the Cessation and Health Systems Change project team here at the Lung Association. I want to invite you to check out our team's website as well as email us if you wish. So on behalf of all of us, I want to welcome you to our webcast today, American Lung Association's webcast on sustainability in cessation, strategies for health systems change. I'm so delighted to see so many of you here today from state tobacco control programs, public health professions, clinicians, and other partners that are joining us today for this very important discussion. So my name is Rebecca Padilla. I'm a National Senior Manager for Tobacco Programs at the American Lung Association, and I want to remind everyone that today's slides will be available via the QR code that will be made available at the very end of today's presentation. So again, thank you so much for joining us and welcome. We have a few goals today for really understanding what our key objectives are. So we want you to leave with a clear understanding of effective strategies for sustainability that can be implemented within health systems and community-based organizations. So these strategies, we hope, will help you develop relationships with stakeholders in areas of high priority, specifically looking at quality improvement, population health, and patient health outcomes. So we have four main objectives with today's webcast: to discuss key components of sustainable health systems change and tobacco cessation interventions, to explore innovative strategies for enhancing cessation, particularly through leveraging technology and partnerships, to address funding challenges and identify creative solutions to broaden our reach and impact, and to help you identify some resources available to support cessation. So I want to encourage everyone today who's watching our live webcast to use the chat function during the live webcast today as we go through our presentation, and let us know what questions you might have about sustainability and cessation, and what challenges are you encountering when it comes to addressing sustainability. We'll do our best to answer these questions when it comes time for our discussion. So we have a packed agenda today with expert speakers who will share their insights and experiences. And we'll start with an in-depth look at sustainability in tobacco cessation interventions, followed by innovative strategies for health systems change. We'll then address the critical issue of funding challenges and explore some potential solutions that you might be able to implement in the settings that you work in. So we'll cover all of that and still carve out a few minutes for Q&A and discussion with our experts. So again, I highly encourage you to please chat with us by using the chat box if you're watching this webcast live. So we'll do our best to answer any questions you might have. And if we can't answer them today, we assure you we'll do our best to get back to you. So before we dive into our agenda, let's take a moment to reflect on why our work is so crucial. Tobacco use remains the leading cause of preventable death and disease in the United States. And every year it claims lives of over 480,000 Americans and costs our nation billions in healthcare expenses and lost productivity. Our efforts to combat this epidemic are more important than ever. And as we all know, the landscape of tobacco cessation efforts is constantly evolving. We face new challenges, particularly in light of funding decreases and how, these challenges also present us with new opportunities for innovation and growth. So today we're going to explore those strategies to help us maintain and enhance our tobacco cessation interventions so that we can ensure that they remain both effective and accessible to those who need them most. So the Surgeon General's report in 2020 on smoking cessation showed us a few key facts: that nearly 70% of all adults who smoke say that they want to quit, that each year over 50% of adults who smoke try to quit, and that more than 3 out of 5 US adults who have ever smoked cigarettes have quit. And although the majority of people who smoke cigarettes make a quit attempt each year, less than 1/3 use cessation medications that are approved by the US Food and Drug Administration, that's the FDA, or use behavioral counseling to support those quit attempts. However, the US Surgeon General's report also presents findings that underscore the challenges we face to further reduce smoking. Over 40% of adults who smoke do not receive advice from a healthcare professional. And fewer than 1 in 3 adults who smoke use cessation counseling or those FDA-approved quit medications when they try to quit. And fewer than 1 in 10 US adults successfully quit smoking each year. And that's why the work we do in health systems change and in those cessation interventions are so, so critical. A few more key facts to remember as we go through our presentation today. Tobacco dependence is a chronic relapsing condition that requires repeated interventions and long-term support. And folks who use menthol and young people may have more difficulty in quitting, and they may need additional support. Future smoking-related illnesses, deaths, and costs can be prevented by helping individuals who use commercial tobacco products quit. And we know that evidence-based treatments, including counseling and FDA-approved quit medications, are available, but they're often underutilized. So again, I want to thank you all for being here today. Your dedication to tobacco control and public health is truly inspiring and what brings us to work every day. So now let's get started with our speakers as we delve into our key components of sustainable health systems change in tobacco cessation interventions. So I'm excited to introduce you to our 2 guest experts today. But before we do that, we want to know just a little bit more about you in our audience. So I would love to kick off our first polling question. So I'd like to ask my teammate Eva, can you share our first polling question, please? We would love to know, how would you rate your current knowledge of key sustainability strategies for cessation interventions? So go ahead and rate yourself. This won't attach to your name, so it's completely anonymous. Maybe you're not at all knowledgeable. Maybe this is your first introduction to sustainability in cessation interventions. Maybe you're somewhat knowledgeable, maybe slightly, maybe moderately knowledgeable, or maybe you're extremely knowledgeable and you're one of those experts in the field. So we would love to know where you stand with that today. So go ahead and pick an answer for us and submit. And then Eva, can you share? Let's see. It looks like most of you are ranking yourself as being moderately knowledgeable. So great. You're in the perfect spot. You're amongst your peers. So with that, I'm super excited to introduce you to our guest experts. So first up is Allison Gorilla. She is an outreach specialist at the University of Wisconsin Center for Tobacco Research and Intervention, and has over a decade of experience working with Wisconsin health systems to disseminate and translate evidence-based tobacco dependence treatments into clinical practice. A focus of Allison's work has been on systemizing tobacco use screening and treatment in facilities that serve individuals disproportionately impacted by tobacco-related health inequities. Allison received her MPH from the University of Minnesota. And Allison is also joined by her teammate today, who will be our second guest expert, and that is Susan Lunston, also an outreach specialist at the University of Wisconsin's Center for Tobacco Research and Intervention. Susan has been with UW Citrus since September of 2021. So along with her experience at UW Citrus, Susan has over 20 years of experience with tobacco dependence treatment in a health system in Western Wisconsin as a tobacco treatment specialist. So as an outreach specialist, Susan works with health systems in Northwest Wisconsin, providing training and technical assistance to staff on evidence-based approaches and best practices to really help people quit tobacco. So I am so excited to turn things over to this team of experts. So with that, I will hand things off to Allie, I think, who's going to get us started.
Yes, thanks, Rebecca, for that great background and introduction. So my name's Allison Gorilla, and I'm just going to start with a brief intro to the Center for Tobacco Research and Intervention. So we are established in 2001. Our center is a part of the University of Wisconsin's School of Medicine and Public Health, and we conduct tobacco cessation research in our offices in Madison and Milwaukee, as well as with healthcare systems throughout Wisconsin and beyond. We also have a regional outreach program, which is where Susan and I work. I cover the yellow shaded region of our state, and Susan covers the much more sprawling and much more rural red shaded part of the state. And it's within our outreach program that we take that evidence-based research and bring it to the healthcare systems all across Wisconsin and help them to integrate it in their clinical services. So health system is a broad term. We work with a variety of healthcare settings, behavioral health, social service agencies, and more recently, criminal legal systems. The second program of our center is the Wisconsin Nicotine Treatment Integration Project, which is really an extension of our outreach work that focuses our training and support to behavioral health providers to help them help their patients and clients quit tobacco. Lastly, UW Tree manages the Wisconsin Tobacco Quit Line for our State Department of Health Services. We are a partner to our commercial tobacco prevention and treatment program, and our outreach program, WinTip and the Quit Line, are funded by our Wisconsin Department of Health Services. Next slide. So I'm going to be covering the first objective that Rebecca shared a little bit about, and Susan's going to be covering learning objective 2 and 3. Next slide. And so for this first objective, you can go on to the next slide. I'll be covering some key components of sustainability, as well as highlighting two sustainability success stories. Kind of a tongue twister there, and what led to their success. So first question, when do we start planning for sustainability? Well, it's well before the intervention gets implemented. for our outreach program, it's often before we even get our foot in the door at a health system. And we're trying to think about who we should connect with, who are the key leaders or decision makers, and who might know those individuals to set up a meeting. And we really try to target those individuals initially or at some points because they are really influential in um, green lighting further access within the system so we can provide that training to their staff. But they're also influential in creating policies that not only prioritize tobacco treatment, but also support staff in implementing and sustaining tobacco treatment. So once connected to those key decision makers, part of relationship development is, I know it's intuitive, but using some of those relational or social soft skills, sometimes motivational intervention skills. So we come prepared to educate. We do our homework and try to look at what some of the organizational mission and goals are and how tobacco treatment aligns with them. But we're also coming prepared to listen and ask questions. And essentially, we want to understand their perspectives of where tobacco treatment aligns with their priorities. We also want to develop rapport as well. And it's not just with the key leaders or decision makers that we want to develop relationships with. We want to, we aim to develop relationships across all levels of a health system. So at the clinic level, we are seeking out those champions. Either physician or nursing champions, management at the clinic level. We also are seeking out partnerships with quality improvement, nursing leadership, and population health. Diverse engagement at multiple levels and across disciplines is so key to sustainability because it ensures you have that necessary buy-in, but also diverse perspectives on questions like how does tobacco treatment align with your mission and goals? How does it fit into current processes? And what factors could support or hinder tobacco treatment integration? So it's just important to recognize that whatever you're seeking to implement at a clinic level, you can't divorce from the healthcare system in which that clinic is embedded. And by meeting with those diverse partners, we're just able to get a better picture of understanding the system, a better picture of the system. At the clinic level, what we're trying to understand are those factors related to implementation, such as clinical workflow, resources, EHR support, staff roles. But at the system level, we're trying to understand what is the larger leadership support for what we're implementing at the clinic level. What is their buy-in? How do they engage staff in implementation? And how did they gather their feedback to improve implementation? We're also assessing capacity for training post-implementation, as well as capacity to monitor and evaluate the program. So often in these initial meetings, I'm trying to gather as much of this information as I can about the clinic and the system and integrating that into the training so that it is tailored to what's being implemented in that clinic and to the patient population the clinic serves, as well as the staff's existing skills, background, and workflow. Sometimes I'm not able to answer all of those questions. And so at the training, after talking about here are the evidence-based treatments, here are the options, we could do an ask, advise, refer to the quit line model, or maybe you have the capacity to do more. But at that point in the training that I'm talking about some of those implementation details about how could these treatments be feasibly implemented in your clinic. And so either way, workflow integration and implementation are key pieces of the training. Lastly, when implementing a new process, we have to monitor and evaluate it. And sometimes those are not always priorities or on the radar of the clinic or health system. And so within the training, I try to build capacity to do that and provide the questions that could be asked informally of staff to understand how a process is working or metrics that could be looked at to understand how a process is working. And then I also make suggestions about just how evaluation could be easily built in. So when it's a tobacco treatment intervention that's being implemented, to view that as a project and put it as a standing agenda item on staff meetings so that that discussion is continually happening around how is what's going well, not well, and getting feedback from people who are implementing it to fine tune the process. So next slide. Another aspect of evaluation is looking at the outcome and effectiveness. And that's really important to elicit continued leadership support for sustaining the intervention. And so REAIM is one framework that has been used to evaluate tobacco treatment programs, and it stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. And essentially, it provides you different metrics that you can use to evaluate effectiveness and the impact of what you've implemented. Assess is can be evaluated by looking at the proportion of patients who smoke in a healthcare setting who participated or were engaged in the treatment intervention. Effectiveness can be assessed by examining quit rates. We also try to provide additional metrics to look at, such as if you are measuring stages of change in a behavioral health setting, and then you've designed an intervention. How is your intervention moving clients up that readiness ladder? So those are different ways to look at effectiveness. Adoption is defined as the proportion of settings that were targeted to implement the tobacco treatment intervention that actually implemented it. And implementation is looking at the provider level, different types of tobacco treatment service delivery. So tobacco use screening, providing advice, referring to a quit line or prescribing are different things that we would want to look at a provider level to understand where additional training is needed. And likewise, we want to understand the clinics and providers who are doing really well in these metrics, what factors are involved there so that we can disseminate that to other clinics in the health system. Lastly, maintenance is defined as the degree to which rates of reach and effectiveness are sustained over time. For a deeper dive into how REAIM was used in cancer centers, and we're going to put a link to an article in the chat that will give you a little bit more of information on how that framework was applied to those centers. If you move to the next slide. So I think we have a poll that is we'll pause and take a poll to assess if you are using a tool currently in your work to assess capacity with sustainability. Okay, so it looks like this might be a great opportunity to share a couple of tools that are out there, because about a third of you said you are using a tool, but the majority aren't. If you are using a tool and you want to just share what tool you're using, you can drop that in the where it says enter your response. So I'll just share that we use a survey that is adapted from a standardized tool called the Smoking Knowledge, Attitudes, and Practices survey. And so if you see SCAP put in there, that's what that means. All right. And then if you have any other tools that you want to drop in the chat, feel free to do that. So wanted to share with you a couple of tools. First, if you go to The link that's going to be dropped in the chat, the ctree.wisc.edu/oncology, that will bring you to the tobacco treatment implementation roadmap. And this is a resource that was developed by the Cancer Center Cessation Initiative, or C3I, and funded by the National Cancer Center. And this roadmap provides practice guidance, examples, and resources that can be adapted to fit your particular needs in the context of your particular clinical setting. Within that roadmap, there is a sustainability module, which discusses sustainability capacity, strategies, financial strategies, evaluation, and impact. And in the sustainability capacity section, there are two tools that I wanted to highlight. The first is a sustainability plan form that C3I cancer clinics use to assess their capacity to sustain their tobacco treatment interventions. And the second is a clinical sustainability assessment tool, which assesses sustainability capacity of tobacco treatment interventions across 7 domains. So if you're looking for a tool, check those out and see if they would be a good fit for you. Okay, if you want to go on to the next slide. And then lastly, before I hand it over to Susan, I wanted to share 2 sustainability success stories in our work. So this first story is an example of how relationships and long-lasting partnerships can lead to policy change, which we know is can have a really broad impact in impacting what happens in clinics and health systems around the state. So for some context, our state has a council of governor-appointed members who are tasked with providing guidance to our state department on all matters relating to substance use disorders. And as I mentioned earlier, our program, WINTIP, focuses on providing training to behavioral health providers. For 13 years, members of our WINTIP steering committee attended those council meetings with a singular goal: to integrate tobacco use into Wisconsin's substance use disorder treatment services. In 2020, an opportunity arose to revise an administrative code that sets the minimum standards for providers of substance use prevention and treatment services in Wisconsin. And at that point, CTRI and others within our Department of Health Services decided to propose language that included tobacco treatment and smoke-free policies requirements. So for 30 years, this administrative code had explicitly excluded nicotine dependence. And it was a long and arduous path, but because of CTRI's longstanding presence on this state council and the support that we had cultivated over those 13 years for integrating tobacco treatment, it was a much easier path to getting the state council's approval for that new tobacco language within the revised code, which they then recommended to the state legislature to approve, and the state legislature did approve. So this is now impacting hundreds of substance use disorder treatment providers and programs in our state who now have to have a policy about how they're going to address tobacco use and treatment in their services. And I just want to share a little highlight, because it happened to me recently, the kind of ripple effect that this policy change continues to have. Many years before this went into effect, I reached out to a substance use disorder treatment program to assess their interest in implementing a smoke-free policy. And they said, nope, not interested, not ready. Well, fast forward this July of this year, that same residential facility reached out to me, now ready to implement a tobacco-free policy, and citing the state code revision as one of the major motivators for them to consider implementing a smoke-free policy. So with my second story, the origins of this story are really about being in the right place with the right person at the right time. And I think we all have encountered this synergy in our work at one point or another. A few years ago, I joined a reentry healthcare task force focused on improving health outcomes of people returning to the community after incarceration. And the co-chair of that task force was the director of a program that provides case management services to people leaving prison who have severe and persistent mental health issues. This is a population we were already interested in reaching in our behavioral health work, but hadn't necessarily reached them through the criminal legal system. So I reached out to him and asked how he was addressing tobacco use in the in his program, and if he would be interested in working with us to provide staff with some training and technical assistance. And fast forward, 4 years later, we are still working with the reentry agencies and have a good working relationship with them. But all along that way, I would provide these progress updates to leadership. And in those progress updates, I would make recommendations and I would frequent the Million Hearts Tobacco Cessation Change Package for ideas of recommendations to make on sustainable strategies. And so the two strategies that I suggested are adopting a tobacco use screening protocol and setting and communicating specific measurable performance goals. And 2 years of recommending those sustainable strategies, their leadership decided to make them requirements within the agency's contracts. So they're now required to address tobacco use within their intake assessments and set a new performance goal on an annual basis. So the take-home message with these two stories is one of relationship development, long-standing partnerships, but also embedding some of these sustainable strategies into policies or contracts is an enduring way of supporting staff and sustaining tobacco treatment interventions. So with that, I am going to pass it on to Susan.
Thanks, Allie, for that background. So I'm going to talk a little bit about some innovative strategies that health systems can consider. And there's many out there, but the one that we're going to focus on today for this presentation is the electronic referral to the quit line. You can go ahead and advance to the next slide, please. So quit lines are a free evidence-based program that help tobacco users quit through individual phone counseling, texting support, or web-based services. And quit lines are effective, yet they're underutilized in clinical care. When quitline referrals are implemented as a part of a larger tobacco treatment intervention, they often drive improvements in other processes such as tobacco use screening, prescribing tobacco cessation medications to patients, and also providing that follow-up to patients. And research shows that when clinicians have a cessation resource to refer their patients to, they're more comfortable discussing the subject and providing that advice. For patients, quitline referrals increase the likelihood of engaging with treatment because the quitline will proactively reach out to them. And so how does embedding the quitline referral process into the electronic medical record or the electronic health record impact implementation and sustainability for health systems? By having that e-referral order available in the record, this makes it assisting patients who use tobacco much easier. It's less disruptive to the clinical workflow, and it's easier to sustain, especially when it's supported by like a quality improvement project that might be requiring tobacco assessment and treatment. And it's a bi-directional interface that closes the loop on quitline referral help to keep providers updated on the patient's progress. The e-referral provides a useful documentation that helps meet reporting requirements related to tobacco use screening and treatment as well. In a study comparing e-referral to fax to quit, the e-referral produced referral rates that were 3 to 4 times higher than the fax to quit alone. And e-referral was particularly effective at increasing the reach of quitline services to patients who smoke and have Medicaid insurance. Despite the e-referral's ability to increase the reach and address smoking disparities, there are implementation and maintenance challenges. So when organizations are rolling out that e-referral across inpatient or outpatient settings within a health system, it can't just be turned on with these features and have different settings. In order for that e-referral to be successfully adopted and sustained, it needs to be prioritized and incorporated into workflows, taking into consideration the staff who are going to be involved with the process, medical assistants, nursing staff, providers, maybe a patient educator. And so the appropriate staff should understand their role in the e-referral, and then there needs to be sufficient training on staff in the e-referral process for that. And lastly, information technology or IT staff will also need to be involved. They're going to need to monitor any issues that may arise with the e-referral being rolled out. It'll be in production and it'll go live. And also when there might be some upgrades to the electronic health record, or there might be some health system mergers. So these are all considerations that need to be taken um, uh, into place regarding the IT situation. So the IT system, they may require some time that will be needed for building that that customized process and also testing that e-referral to make sure it's a successful process. And then for smaller clinics, maybe there's not as much resources available, or the cost and the IT time can be requiring a little bit more than what's available. So that is a barrier for the e-referral. So fax to quit is the standard of care, and that certainly is functional for many, many clinics that we work with. But we're also looking into a version of the electronic referral to the quit line called direct secure messaging. It's similar to email, although it's much more secure and is already being used by many clinics and health systems to facilitate, that secure electronic communication of health information and referrals. And so we're interested to see how direct secure message could overcome some of those costs and interoperability issues and expand adoption of e-referral in clinics that are serving populations with high prevalence of tobacco-related health disparities. And you can go on to the next slide. And so in our last objective, we're going to talk about strategies for addressing those funding challenges. And so whether you're a training and technical assistance organization or you're a health system, securing funding can often be a challenge to sustaining what's already been implemented. And programs that rely on a single source of funding are vulnerable to budget cuts, which is why our outreach program, we try to leverage our relationship with strategic partners whose work aligns with our program's mission. An example of this is that we've got relationships that we've developed with health systems, our Department of Health Services, our tobacco program partners have also enabled us to address tobacco-related health equity priorities, looking at low-income, racial, and ethnic communities, behavioral health populations, youth and young adults, and also the criminal legal impacted population. Ali mentioned some of these relationships that we have that are ongoing and continuing. We've also partnered with academic institutions, technical colleges, professional health care organizations to train their clinicians or maybe their clinician students. And together, these diverse partnerships not only broaden the reach and impact of our work, they also open up potential funding opportunities. The second strategy that we're going to talk about is to look at and consider a business plan. So for health systems who are seeking internal funding to implement an intervention, treating tobacco treatment projects like a business could really help secure that investment. So within the sustainability module of the tobacco treatment implementation roadmap, there's a section on financial strategies that will help you create a business plan to present a clear ask and gain support from health system leadership and other funders. And we're going to include that in the chat, and I also believe there's a QR code for that. Finally, we're going to talk a little bit about tobacco cessation that's traditionally been described as the golden standard. It's cost effective, you get the most bang for your buck, and in a value-based care model that reimburses for quality, not quantity of care, tobacco cessation treatment can have an enormous financial benefit for the healthcare system, the payers, in addition to the benefits that individual patients and the broader population can expect. However, despite this cost effectiveness and of evidence that we have, the costs and benefits and return on investment for tobacco treatments are rarely factored into these discussions. We recently presented a webinar on cost effectiveness of tobacco treatments within our Wisconsin health systems and for our payers. If you're looking for an introduction on how to do cost effectiveness analysis or would like an overview of tobacco treatment approaches shown to be cost effective, please check this out. Dr. Marlon Munt did a fantastic job with the presentation, and we have a recording available on our website, and that will also be entered into the chat. And I believe there's also a QR code for that. Thank you so much. I'm going to hand it back over to Ali.
Thanks so much for listening. And, there's so much collective knowledge about sustainability. We hope we've added a little bit to your knowledge with some of our experiences and lessons learned from our work. And so we look forward to addressing your questions now.
Absolutely. Thank you. I had a quick question for both of you. Earlier on in the presentation, Allison, you mentioned looking at metrics around effectiveness and utilizing metrics around measuring the stages of change rather than just measuring quit attempts. And I think that is such a great approach to showing the bigger picture of how much we do when it comes to interventions around cessation. And I would love to know, are more of the systems you work with utilizing that sort of a metric for their interventions? I would love for you if you could take a minute or two to speak to that. I know we could probably spend a couple of hours speaking to how we measure that, but
Sure. So stages of change is something that we had seen being integrated already in some of the behavioral health programs and clinics that we are working with. In particular, the reentry programs that provide some of the case management work. They were already collecting this information specific to tobacco use and cessation. So that was a really good foundation to build, looking at how what they're putting into place as far as screening and support to connecting clients to quit line referrals or providers in the community for cessation support, or even the discussions that we were training them to have with their clients, how that was kind of moving people who were, we have a training called the bucket approach, which is largely based on stages of change, which puts people into different buckets based on readiness. So how they were being moved up from a bucket of no interest to ready to make some changes, thinking about it, contemplating. So this was one, example of just different ways to evaluate how, what you're doing is having an impact and not, sometimes it can be a little bit demoralizing to just attach value of what you're doing to quit rates. So being able to monitor different ways of, tobacco cessation behavior change is helpful.
I think that's a really great approach. And like you said, it can be kind of demoralizing to kind of boil everything down to just a quit attempt when we know it's such a broader scope in the work to really support someone in their recovery process. So I really appreciate you addressing that. Another question that came up is how do you also spoke to sustainability planning starts before you walk through the front doors. How do you specifically engage additional champions in health systems? So something our team has encountered a lot of times when providing support and training and technical assistance to folks is oftentimes great, interventions, great cessation programming kind of goes out the door with a key champion sometimes, especially in smaller organizations or smaller systems. So how do you engage additional key champions and stakeholders in systems that you work with?
Yeah, I'll start in, Susan, if you have ideas. Sometimes it's not always engaging additional folks, but it's being strategic about the one person you want to maintain a connection with, because remember, we're just a program of 4 staff. So we do try to be strategic around, if it's a clinic manager or supervisor that we really try to create a strong connection with and keep that connection so that if there's staff turnover, we can then work with the clinic manager to address, training those staff. And, what if the clinic manager leaves? Well, we continue to try to communicate with the clinic to foster that new relationship.
Yeah, thanks, Allie. And I would add to that I believe we have a fantastic working relationship with our area alliances throughout the state. And so a lot of them, live in the community that they are working with and being impacted by. And so the alliance members can be a true go-to in regards to looking at opportunities to make new connections if there's been some staff turnover or organizational change. And so I think continuing those conversations with the alliance members is very, very helpful as well too as staff turnover occurs, unfortunately.
Awesome. Thank you so much. We love that. It looks like we had someone mention about referrals to the quit line, potentially billing for those as well. Do you give a lot of technical assistance around billing to your systems that you work with? I know that can be an area of contention. American Lung, of course, does have some great billing guides available. If anyone's interested, we'll give you the link for how to access those in just a moment as well.
Yes, we do share a lot of resources around that. You know, so the cost effectiveness discussion has to be more encompassing than reimbursement rates because they're quite low. But when there's interest in improving billing and reimbursement, we definitely share those resources from the ALA and also our state resources specific to our Medicaid reimbursement. And we recently learned that our Medicaid program does um, cover smoking cessation for pediatric providers who provide support to youth and young adults. So we're constantly learning and providing, new resources and knowledge to our providers.
Wonderful. And that's where it's really critical that you maintain those clear lines of communication with all of the stakeholders that, have those shared objectives in the community, right? Staying in touch and educating yourself on Medicaid in your state, on the different payers in the state, and ensuring that you're communicating with your clinical providers as well. Wonderful. So we would love to take just a few moments here to kind of rehash a few key takeaways with everyone and share some really important resources as well before we ask you to share your feedback with us. So again, our team firmly believes that wherever there's a challenge, there is a clear opportunity to address it. So that's definitely the case with the challenges we face in building sustainability into cessation interventions. So one of the key components here is building partnerships to prioritize cessation in your community really equates to sustainability for your interventions. So some ways that you can do that, again, going to those community-based organizations, connecting with care providers, different groups, coalitions, representing the populations that you're really prioritizing in your community and those that are most impacted by commercial tobacco use. You can share insights about your community or about how cessation could better support those members of your community. You can help develop strategies for state cessation programs. You can help with promoting quitline services. And you can also work with developing and adapting ads for specific communities or population groups by connecting with those community-based organizations or those groups that represent specific populations within your community that you really want to help support with cessation. So again, like I mentioned, we have some great resources and tools as well as additional technical assistance for you. So we have all of those wonderful links that Allison and Susan shared with us. We'll be sure we share those with you all again. We also have a great toolkit that our team here at Lung created a couple of years ago, all around enhancing your partnerships in health systems and in the community. So you can use the QR code on the screen right now to directly access that. And of course, the tobacco cessation change package is really a wonderful, expansive toolkit that will take you through every step of the way of integrating tobacco cessation through a health system. And it's got lots of tools for different settings. And our team has also created companion tools specifically for folks that work in public health and not in a clinical setting to work with the tobacco cessation change package. So those are the extra roadmaps that you see there on the screen as well. So you can access all of those through the QR code on the screen. There's also a wonderful 5-minute tutorial on how to use the tobacco cessation change package. It'll be in today's slides as well. And finally, you can access all of these tools and so much more on lung.org/cessation TA. We have an amazing resource library there. We've got lots of tools on there from our friends at UW Citry, as well as other partner organizations, as well as all of the great resources and tools that our team has created. With input from folks just like you who have helped guide us and provided input from the field on what really works to help implement effective cessation and impactful health systems change throughout the country. So with that, your feedback is incredibly important to us. So I would like to ask all of you to either take your mobile phone and scan the QR code on the screen, or you can click the link that my teammate Eva just dropped into the chat. And please take just a minute or two to share your feedback with us about today's webcast. It will just take a couple of minutes, and we would love to get that feedback from you. So with that, I want to thank you all so much for joining us. Susan, Allison, is there any closing words you want to take us out with today before we wrap up?
Well, thanks so much for the opportunity to present. I did see a question in the chat. I don't know if you saw that. I didn't want to, I know we have a little bit of time.
Oh, we do. Yes, absolutely. Let's see. Um, is it on the billing for visits?
There's one from, it's regarding getting data from health systems to monitor intervention outcomes or checkpoints can be challenging. What other external data sources are you aware of to monitor and evaluate systems change?
Great question.
One kind of relationship that developed was with a contracting organization with Medicare that looks at data on billing uh, for cessation counseling and prescribing practices. And this relationship has been beneficial because they've been able to directly share with us data on, if they kind of are able to flag clinics and even at the provider level and health system, um, areas where there's need for improvement in billing for cessation, counseling, and prescribing practices. And so that's been an interesting way to collaborate with a contracting organization with Medicare. They don't have the access to the health systems that we do, but it's something we are looking at using potentially to just provide further education around billing. And that often opens the door to, well, what are you actually doing during clinical practice to help your patients to quit? That was one thing that came to mind.
That could be super helpful. Thank you. Susan, do you have anything else to add for that?
I was just going to echo what Allie had said, that it with that information we're able to expand it, as Allie had indicated, to above and beyond that billing piece of how are you having those conversations, and maybe revisiting that, and looking at again that whole team approach and providing those resources to the team members to enhance the patient experience as well too.
And do you find that oftentimes that's really what it takes is getting that conversation going?
Yeah, and I would say that sometimes quitline referral is like the way in because it's a low intensity intervention, but you have to do the screening piece before that even takes place. So it is one way to just kind of take a closer look at everything that's being done in the clinic setting is through the discussion around quitline referral and integration.
Yep, and I would echo that as well too. Yep, that just it's the starting point, and it's a warm handoff to additional resources, and that patient can be getting quitline resources and services, but then also getting great support from their patient care team as well too.
I think that's incredibly important to stress that quit lines can be utilized as an adjunct to care. And we know the more support a patient can get, the better. So I think that's really great to stress that. I want to say that someone just shared the link to the webinar that you mentioned that Dr. Munt had done on cessation treatment from an economic perspective. So thank you so much for sharing that. It's a great link for us to share as well. Appreciate that.
Yeah, thank you for posting those articles further up. And yeah, Dr. Marlon Munt is our center's health economist, and he explains things in plain language, which is really great when it comes to complex, what I think is complex analysis. So
100,
he did a
yes,
great job.
that's very helpful to have it in plain English. Absolutely. Well, I want to thank you both so much. And I want to thank everyone that was able to join us today. We appreciate you taking time out of your afternoon to join us. And again, thank you for the important work that you're doing to help people on their road to recovery every day, to helping them quit. Uh, thank you so much. And again, have a wonderful afternoon. You can access today's slides with the QR code on the screen. And thank you so much.
Thank you.